Hello. Today we're going to discuss all the ways TCD or transcranial Doppler can enhance your patient care. What reasons would you perform TCD? There are many, from sickle cell, ischemic stroke, intracranial stenosis, TBI, brain death, internal carotid artery disease, moya, vasospasm, PFO, emboli monitoring, cerebral vasoreactivity. Today we're going to discuss vasospasm, PFO, sickle cell, brain death, and VMR. Just briefly, what TCD is we're using a 2 megahertz pulsed wave single element transducer. We're insonating through windows, typically temporal windows. We're looking for thinnest layer of bone to insonate through. And we are trying to find these arteries at the circle of Willis, the base of the brain, and we are finding the mean flow velocities, the pulsatility indices, anything that resembles emboli or a bubble in those arteries. And just an overview of what we're seeing on the screen and how it resembles and relates to an adult skull. So over here we have an adult skull with the probe placed at the left temporal window. We have our depths in millimeters here from 30 to 80. This will display on our M mode or motion mode with blood flow towards the probe as red, blood flow away from the probe as blue. So we can see where 30 and 30 meet here, and 40 and 50. We have our middle cerebral artery coming up here, coming towards the probe. And since it's coming towards the probe, it's red. And we see at 60 here, this MCA is coming towards the probe all the way to 30. We see here our ACA is going away from the probe at about the depth of 60 millimeters. So at a depth of 60 millimeters, we have that flow going away from the probe in blue. At 75 millimeters, it's typical midline of an adult skull. So always be aware at 75 to 80 millimeters, that is going to start the other side of the head. So we have our MCA on the left, ACA on the left, our right ACA and our right MCA. The blood flow that we see down here in the spectrogram is isolated to a single view, and that is wherever we have our depth located. Here we have our depth at 50 millimeters, so we have blood flow going above the baseline because it is going towards the probe. Once we change our depth to 70 millimeters and we isolate our ACA, that spectrogram will display flow going below the baseline because it is going away from the probe. The reports will display a circle of Willis image, and as you see here, we have our internal carotid arteries here in the front, our middle cerebral arteries on both sides, our ACAs connecting in the center here, and our posterior flow with our vertebrals, basilar, and our PCAs up here, and our PCOMs connecting to the anterior circulation. We'll have waveforms, high-quality waveforms that show the M mode display we just reviewed, and the spectrogram for each of these vessels that you'll be able to select each arrow and see the image that was taken at each of these snapshots. The system will analyze the time average mean maximum velocity for us. How the system will calculate this is it will take 4 cardiac cycles and it'll do a 3D analysis, 125 slices per cardiac cycle. So of the 4 cardiac cycles, it'll be 500 3D analysis slices analyzing and providing us with the most accurate time average mean maximum velocity that will be conveniently displayed on the corner of our screen. Along with the time average mean maximum, we will also look at the pulsatility index, or PI. The system will generate a pulsatility index, which is 1 peak minus n divided by the mean, and 1.2 and above will be your high pulsatility index. An index of 0.4 and below is going to be your low PI. You will see different waveform morphology characteristics for a high PI versus a low PI. Your high PI is going to have a lack or loss of end diastolic flow, as you see here in your PI of 2.5 and 2.0. This is your normal waveform with your PI range of 0.8 to 1.2. Your low PI is going to have that extra end diastolic flow. So you'll see here with a PI of 0.4, there'll be a higher end diastolic flow within that waveform. As you can see with flow traveling normally, at a normal state, you'll see these normal waveform morphology. If there is a type of narrowing, vasospasm, stenosis, whatever is causing that narrowing, you'll see different waveform morphology changes. You'll have a high PI right before that narrowing, a low PI, a high mean at the narrowing, a low mean, and a low PI after the narrowing. And here is the neurosignal platform overview. You can see the head cradle here that holds both of the propods advancing to the skin surface. Indicator lights acknowledging the right amount of pressure and symmetry with alignment of our patient. We have the full system displayed here. On the side, you can see we have holders for those propods, so we can wheel this cart bedside from room to room conveniently. We also offer the NovaGuide View, a cloud-based app, how you can connect, you can stream in live, where you can watch your exam being performed in real time, and you can review exams on your phone, on any computer. You can receive notifications if you're following a specific patient and you would like to be alerted of any critical results. And here's what the NovaGuide View platform will look like when you log in. You will see all of your exams initially, and then when you scroll through, you're able to add anything that you would like to add, from conclusions, technique description, interpretation, risk factors. You're able to select any image to review on that circle of Venus. Not only visual, but you can have audio combined, reviewing for vasospasm, bubble studies, emboli, anything that is performed on the system. There is a unique 3D circle Willis display as well. The system will walk you through every step that is required for setup. It will show you that stickers are required to be placed at the corner of the eye and tragus of the ear. Gels required between the stickers. The head cradle should be set up symmetrical to the patient's shoulders, and the eye-safe laser should be used to align the patient's nose and chest. Once we select next on this screen, we will see the screen on our right here. It will have live cameras that will register all 4 of these stickers or fiducials, and it will plot out the square or area that the robot will scan. Next, we'll do a brief overview of bubble studies. So why do we do TCD bubble study? It has been proven to be 3 times more sensitive than echo TTE. So this is side-by-side comparison showing actual patients that had TTE that completely missed the PFO. And these aren't small shunts being missed, they're large shunts. And you can see all of the bubbles detected on neurosignal TCD systems here, these very severe high-grade shunts that were found and completely missed on TTE echo. The bubble exam workflow is an agitation of 9 cc's of saline, 1 cc of air, half cc of blood drawback, 10 vigorous cycles, and 2 injections. You'll do 1 injection at rest and 1 injection with Valsalva. We'll look for the bubbles as you see here on the screen. We will identify the higher concentration of white within the M mode, along with the higher concentration of white within the spectrogram. A unique popping sound you will hear along with bubble identification. We will identify small versus large shunts by the bubble count. So you can see here, this is Spencer grade. So a Spencer shunt grade 1, 3, and 5. Significant shunt grades are 3, 4, and 5. So once we see bubbles that reach 31 and above, those are your significant shunts. The system will walk you right through this. So once you enter in your bubbles, it will multiply and provide that shunt grade for you. So you will have the reference chart on the bottom corner, but there's no need to memorize this because the system will do this all for you. And here is a full exam being performed. You can see your waveforms here on the left. The solution is being mixed and injected. This is a calibrated Valsalva. by using a manometer here. Once the patient releases his breath hold, you will see all the bubbles present. Review emboli monitoring. As we mentioned, we could do TCD for so many different reasons. However, all the different reasons we perform TCD are not particularly the gold standard. Angio and CTA will take precedence. However, for emboli monitoring, TCD is the gold standard. There is no other modality to test to see in real time there is an emboli or something traveling within that blood that should not be there. CT, you can see when something traveled and caused damage in the brain. However, you cannot see in real time that there is emboli traveling currently in the blood. So with TCD, you can. We are able to identify emboli on a TCD, and it will have the same unique sound, a popping, chirping, snapping type sound as normal cells. It will have the higher concentration of white within M mode and in the spectrogram, and our system will identify these high intensity signals on each of the images for us. Next, we'll review briefly vasospasm. Comprehensive stroke centers require TCD. So vasospasm is one of the most common applications TCD is used for. When we find vasospasm on TCD, there will be a high pitch, as you can hear here. And vasospasm will be common in our subarachnoid hemorrhage patient population. 70% of subarachnoid hemorrhage patients will develop vasospasm. Since our M mode or motion mode is amplitude, welcome dogs to the presentation. You will be able to see a black dot or dropout on the screen at the areas of the most narrowed segments. There is less red blood cells being reflected back, and so we can easily identify just by looking at the M mode where the highest mean velocities are located. Our vasospasm criteria is for our MC and terminal ICA to distinguish mild, moderate, and severe categories. We will base that off of these mean velocities of 120 to 149 for our mild range, 150 to 199 for our moderate range, and greater than 200 for our severe range. Of course, we need to look at that Lindengaard ratio. We need to compare the flow from our extracranial ICA to our highest middle cerebral artery mean velocity, and those ratios between 3 and 6 are mild and moderate, and greater than 6 will be your severe range. Here is side-by-side comparison of what that mild, moderate, and severe will look like. You will look at that mean velocity. Here's 132, that is your mild range. Here's 164, your moderate range, and we said over 200, severe range vasospasm. With vasospasm, it's important to see the day-to-day trending. So we will look for the highest mean velocities and Lindengaard ratios from each day. And we will have a trend display on our reports that will show a quick view of what day the mean velocities significantly increased. And here is a case study on a vasospasm or subarachnoid hemorrhage patient. We had a 26-year-old Caucasian female, status post-tumor resection and ACOM aneurysm coiling, as we said, with subarachnoid hemorrhage. This patient had no clinical symptoms. So there were no symptoms to suggest vasospasm, and TCD was performed daily. And on this day, we found mean velocities elevated in the left MCA of 202, and bilaterally the ACAs were elevated. That cutoff is 130, so 137 on the right ACA and 176 on the left ACA. A CTA was performed after the TCD found these elevated mean velocities, and the CTA confirmed vasospasm. Verapamil was administered to decrease the mean velocities, and prevent stroke on this particular patient. Moving right along into sickle cell. With sickle cell, we'll check the same thing. We'll check the speed of the blood flow, so we'll want to know what the mean velocity is. However, they will be higher at normal state, so it'll be a higher threshold. 170 will begin abnormal. Well, below 170 is your normal range. 170 will be conditional, and greater than 200 will be your abnormal range. Your case examples for sickle cell, your normal 95 time average mean maximum, your conditional range 189. This white line is your envelope tracing, and that is what is providing us our mean velocity. So we want to make sure that white envelope is tracing that waveform accurately. When the measurement needs to be made manually, we can do that post-processing and put a cursor at the peak and the end. And you see here, this is our abnormal mean velocity for our sickle cell population. As we know, TCD is well established for identifying the stroke risk in our pediatric patients with sickle cell. So we need to ensure TCD is part of the process of providing the best patient care for our sickle cell pediatric population. And moving right along into brain death. The TCD morphology progression with brain death will have different stages. We will see ICP changes along with the TCD morphology changes. We will see an elevated PI, a reduction in the end diastolic flow in our waveform patterns. We'll see the MCA anteriorly, bilaterally, and our basilar artery posteriorly. We'll also take a look at our extracranial ICA to see that increased resistance in that vessel as well. Here's a case example of a positive brain death exam. You'll see the reverberating flow here, the flow above the baseline and below the baseline. Almost a thumping signal is what you would hear. Going back and forth, you'll see the red and blue. It's coming towards the probe and going away. And you can see the timeline here, the progression of the waveform pattern, how it changes. You can see it go to a triphasic signal, to a biphasic signal, short systolic spikes eventually before the flow cessation. As we know, it is required to obtain the bilateral MCAs and basilar artery for cerebral circulatory arrest or your brain death verification exams. 2 exams are preferred, 30 minutes apart between each of these exams, and you would need to identify the biphasic, oscillating, or short systolic spikes in all of these vessels, because you can find a signal such as this in an occlusion on one side in one vessel. So we do need to find it in all vessels to conclude or suggest brain death. Here is a case example showing pupils fixed, not dilated at 4:20 p.m. and this is the image obtained. 11:30 p.m. Positive breathing on apnea trial, and then at 3:30 p.m. no neurological functions on the negative apnea trial, and this is what the TCD showed at that time. Up next is vasomotor activity, or VMR. With vasomotor activity, we can perform these exams with a breath holding index or with CO2. Breath holding index is common. What we are doing is when we hold our breath, our CO2 levels will increase. The arterioles will dilate and allow more blood flow in a normal response. So we'll see increased mean velocities with release of the breath hold, and we'll have a certain range that the breath holding index should be for normal state. A breath holding index workflow will be to isolate the bilateral middle cerebral arteries and have the patient hold their breath, preferably for 30 seconds. We will mark the baseline and 4 seconds after the release of the breath, and the system will do the calculation. As we see here is the equation. We do not have to memorize this, luckily. The system will provide our breath holding index for us, with, we said, 0.69 and above being that normal state. If CO2 is your preferred way of performing a vasomotor reserve exam, that can be done as well with the NG2 system. You will see the different calipers marking on the timeline for your baseline, the beginning of CO2 and the cessation of CO2, and then your normal and impaired VMR numbers are greater than 65% for normal and less than 33% for your impaired VMR with CO2. Another way of using TCD is in the operating room. We have used TCD for many heart procedures, for CEAs, for many different surgeries, and we can monitor in real time if the blood flow changes, if there are multiple emboli, and anything else that the surgeon would be interested in seeing in what the blood flow is doing during these procedures. As you can see, we are able to put this system on patients when there are so many things in place, and we can easily fit in an operating room when there are so many things around the patient as well. With Neurosignal, we offer a unique application called morphology. Morphology will analyze the whole waveform, and we will briefly review that next. We also have a morphology package with our NG2 system. So with morphology, we are doing an analysis of the whole contour of the waveform, and index is provided to us, a velocity curvature index, which can be almost like an enhanced pulsatility index, where you can easily see 5.4 is your normal velocity curvature index and 2.6 is the blunted state. We have a P2 ratio, so you can see the difference between your P1 and P2 slopes and showing that decreased distal vascular compliance in the vessels. So we offer this unique morphology that can potentially be a breakthrough for monitoring cerebral blood flow with TCD. That is all we have for today. Thank you for your time and attention.